The challenges we face is I think the first one will be access to clinical trial. We would like to enroll most of our patients with myeloma in a clinical trial. At the moment, we have a clinical trials for transplant eligible patient, but we don't have any clinical trial for transplant eligible patient. Certainly, with the revolution in multiple myeloma treatment, we have patients who either used IMiD or proteasome inhibitors upfront, and the relapse after what we call them either double refractory or triple refractory after incorporating monoclonal antibodies. I think that cohort patient we don't have any access to, for instance, a drug conjugate or bispecific antibodies or CAR-T therapy, although hopefully soon we will be able to have access to CAR-T therapy for myeloma patients in Ireland. So that's a cohort of patients who have exposed to the available fantastic treatment, but unfortunately their disease progress where they become either double or triple drug refractory. How to deal with them? Just we have a very limited access to the new drugs in development for that patient context. Certainly, we have a few patients with aggressive relapse, like CNS relapse, with multiple myeloma. For sure, we have access to monoclonal antibody and second generation, third generation IMiDs. But again, it's a very challenging disease when it's presented in CNS as a CNS relapse. The last thing will be, even though we have a very good treatment available, there's emerging a new side effect with different new drugs like cardiac toxicity with carfilzomib, or we have issues with peripheral neuropathy, and that sometimes is very challenging. You'll have the disease well controlled, but the side effect profile sometimes limiting any further exposure to the same drug which we have achieved a very good response with.